I think this is one of the most fascinating meetings that I get to attend, and so I really appreciate it and hope that I can motivate you all or give you some interesting information about what's going on with the epidemic. Just to start with, no personal conflicts. As I was putting this together, it was really sobering. It was really disappointing and kind of sad because I thought, oh yeah, I did this presentation 2 years ago. Let's see what's changed. Let's see what's really happened based on all of the additional information that we've gotten in terms of how do we deliver programs for children and adolescents and pregnant women. And what we see and what I'll show you is that it's quite disappointing. There's not much change. There's not much difference in the last 2 years, despite the improved understanding of what works in epidemics. And I think of 2 years ago when George Cyberry was presenting about the acceleration for child treatment program and how we were figuring out, like, oh yeah, there's many different ways to try to reach children and identify children living with HIV that are not on treatment. And yet we still haven't, 2 years later, been able to see that in our numbers. The one thing that I can say is that we do have some more confidence in the data that we are presenting to you today, and that's a positive thing. One thing is we have, through a lot of efforts, I think speared by the US government primarily, was to go back and look at some of the numbers, the program data on numbers of people on treatment and numbers of women reached with PMTCT to try to improve those data. So that's helped us through data quality assessments. We also are directly using HIV prevalence data from every time a pregnant woman goes into an antenatal clinic, she's tested, that's a data point. And we're using that now. Instead of just saying like, oh, well, it's messy, it's not quite tidy enough, we're taking that data and putting it directly into our models to help us understand the epidemic. Suzui Saito last year presented data showing that the estimates were similar to the survey data that was coming out, kind of giving more validation to these estimates. We've looked at them again this year, and they're still consistent with the surveys, the additional surveys that are out there, so that's good news. We have a new estimate from Nigeria. They did a new survey that brought down the estimated number of HIV-positive pregnant women by about 40%, a huge difference than what was in the previous surveys. That's obviously affected our models, and in a good way. Unfortunately, it's offset to some degree by changes in other regions like China and other Asian countries where the epidemic's gone up, so you don't see a big shift there. Finally, just to remind you, when we do create these estimates, we do update the historical estimates as well. So it's not that you're going to see a sudden change in Nigeria for 2018 and that's not reflected in 17, 16, 15, et cetera. We do go back and update the historical estimates. And finally, one point is to say that these estimates are produced by country teams and then UNAIDS compiles them. The data that's going into the program data is reviewed by WHO, UNICEF, US government, Global Fund, and other partners to help us really scrutinize those data. But the data are produced then and put into a model by country teams, and UNAIDS is just compiling them. So I'm presenting for many, many people around the world. So here's the data that looks very similar to last year. If you think of, or 2 years ago, the progress in reaching pregnant women with ART. You can see that globally we're at about 82% coverage of women who are in need of PMTCT services, while in Eastern and Southern Africa we've gotten to 92%. That's great, but look at Western and Central Africa where that decline is happening. The decline that you see between 16, 17, 18 is primarily due to Nigeria, where the number of women reached, so nothing to do with their survey, nothing to do with models, the actual number of women that are reached with services has gone down from almost 60,000 to about 43,000. So something needs to be done there to kind of reinstigate the push to reaching women in Nigeria. One of the things I think that's useful to look at is to try to understand the number of HIV-positive pregnant women. That's been very flat over many years historically. But if we break that down by age group, it's interesting to look that among young women, so this slide is showing the absolute number of births, not a proportion, the number of births among HIV-positive women. The orange line is the women who are 25 to 49. The blue is 15 to 24. And what you can see from this graph is that among the young women, because of declines in fertility and declines in new infections among young women, we have seen that value going down. So that's a good instigation to say, okay, where do we look for the women who are HIV positive and pregnant, and not to leave those women who are 25 to 49 behind. We need to focus on the whole age range in that demographic. So what does the impact of that PMTCT coverage results in about 63% decline in new child infections since 2000. We've missed the 2018 target, which globally we had set at reaching, having only 40,000 new infections or less than 40,000 new infections by the year 2018. Obviously, we're far off that. We're at 160,000 globally. So how do we understand that last kind of that flattening of the curve going down? One of the things that we're really helping countries with is understanding where did those new infections come from. And apologies for those of you who've seen this slide before, but I think it's quite a useful slide. And what it's trying to say is the y-axis there is the number of child infections. And so, for example, in the third bar there, Western Central Africa, you've got about 46,000 new child infections that take place in the countries in this analysis in Western and Central Africa. What is the problem with our PMTCT services that we're still getting new infections, those new infections? And so what this slide does, and what this tool does, is it says, okay, the vast majority of the new infections in Western and Central Africa are because of women who did not receive any ART. So they're just women missed altogether by the program. That's the yellow. The orange bar is saying this is the proportion of women who seroconverted. So they were either became HIV infected during pregnancy or during breastfeeding, and as a result, they transmitted to the child. And what you can see from these three bars is the difference between Eastern Africa, Southern Africa, and Western and Central Africa. Western and Central Africa, it's primarily because women aren't getting reached with services, just basic PMTCT services. Eastern Africa, it's more about the gray bar, which is about women dropping off of treatment. They're not being retained, so at the time of delivery, they've dropped off of ART and their chance of transmission is higher. Same thing with during pregnancy and breastfeeding. Finally, in Southern Africa, as you can imagine, with very high incidence in that region, there's a lot of new infections because of women seroconverting during pregnancy and breastfeeding, and that's leading to a lot of new infections. So it's a complicated graph, but countries are producing this in their software and able to go and analyze this and decide where to move their program. So quite useful to get that last 20% of women, or to close the gap of the 160,000 new child infections. So now switching over from PMTCT kind of to pediatric ART. Again, we set a target to try to get 1.6 million children on ART by 2018. We're far off. We're at 940,000 as of end of 2018. You can see that curve slowing down as we're trying to reach those children, but not necessarily finding them. And I think that's an important point to think about. How do we find them more? And I'll come back to that in a minute. So if we look at coverage then, we can see globally, it's like 54%, and I feel like I said the same thing, or maybe I think it was like 50 or 52%, or it was around half 2 years ago, and alas, we're still there. So we're not making huge increases there. Eastern Southern Africa, there's a lot of good stories there with countries that are reaching children. So in the region as a whole, they've reached 62%. So Western Central Africa, however, down at 28%, so very, very low. If we look at the treatment cascade, so something that UNAIDS and other partners are really pushing is looking at where do those children fall off of care and why aren't they virally suppressed. We can see this for a handful of countries. And so what I'm showing you here is a percent coverage. The blue bar is the proportion of children who are diagnosed. And as you can imagine, that's a value that's not collected easily and commonly in countries, because usually most kids will go straight from diagnosis and put on treatment. So you'll see a lot of countries, the blue and the orange bar are the exact same, because we don't actually know the difference between the children diagnosed and on treatment. Among those on treatment, the orange bar is fairly, you can see it's fairly poor. It's around 50% for a lot of these countries. Then the drop to the gray bar is the important drop too. So those children who are not virally suppressed among those on treatment are described in the gray bar. So quite a concern, saying, well, why is that drop so much? Why is it so much bigger than adults? And something that we'll need to come back to, and I think it will be discussed later in other presentations. Just as a comparison, so the gray bar is country program data that was submitted to UNAIDS and partners through the Global AIDS Monitoring System. The yellow bar is data that comes from FIA, which is household survey data. It should be representative of the country and fairly robust. And so what you can see there, for the most part, is that those program data coming from countries and the FIA data are fairly consistent. There's a few outliers, Tanzania and Zambia, that we're still trying to understand a little bit more of what's happening there. So in general, though, the viral load suppression is the challenge among children. So not only are they not on treatment, but even when they're on treatment, they're not becoming virally suppressed. So where do we find these children? Showing the data of the number of children living with HIV, 1.7 million total, we can see that 2 out of 3 of these are in Eastern Southern Africa. 50% of them are in 6 countries, so we know where to find them. The other way to look at it is to look at them by age groups. And I think this is important. We've shown this before, but it continues to show that the number of children in that youngest age group, 0 to 4, is declining and going quickly because of the success of PMTCT. We've got a lot more children in the 5 to 9 and 10 to 14-year-old age groups, and we need to look at those age groups carefully to figure out how do we find them, how do we reach them and get them in services. This is the same kind of bar, except I've put the 15 to 19s on there, and it's only for the year 2018. So what I'm trying to stress here is that this varies very much by countries. It's quite different if you look at Angola, where there's still a lot of, over 30% of children are 0 to 4 living with HIV, versus a place like Rwanda, Botswana, where it's less than 10% in the 0 to 4 age group. So it's important to scrutinize this further and look at which, within the country you're working in, how do we know what's the age distribution of these children? And then to look at how much that's then impacted with the 15 to 19-year-olds, looking at the additional children in that age group who are living with HIV, or sorry, I shouldn't say children, the additional adolescents, 15 to 19-year-old. So moving on to AIDS-related deaths among children living with HIV, you can see that the decline is coming down over time from 2010 to 2018. That's great. That's slowing, mirroring the ART coverage in the countries that I showed before. The other thing I just wanted to pull out was the AIDS-related deaths by age group. And so that right-hand bar there shows the gray is the 15 to 19-year-olds. It's very flat. There's tend to be a lot of newly infected children, I keep calling them children, 15 to 19-year-olds, adolescents living with HIV. Mortality is not fluctuating much over time, whereas the blue bar shows the 5 to 9-year-olds and the nice decline in AIDS deaths in those children, as well as the 10 to 14-year-olds and declines in those children. So just one last point I just want to make in these last 2 slides is to mention the importance of looking at not just the children living with HIV, but those children who are HIV exposed but uninfected. And so we've been working with Amy Slogrove and Kate Powis recently to pull out some data to look at that globally. About 15 million children, less than 15, are exposed but uninfected. If we break that down further by country, you can see that in a lot of the very high prevalence countries, that proportion of children who are HIV exposed and uninfected is quite high, getting up between 20 and 30% in some of these high prevalence countries. So something to look out for. But also to consider that as ART rolls out, that blue area under this bar, the proportion of children who are HIV exposed and uninfected is going to be more and more ART and HIV exposed, so hopefully having better outcomes than just the HIV exposed children. To wrap it up, I think the most important thing is to really, well, I shouldn't say most important. One of the key things here is to really stop the gap, the tap, close the tap of countries and help them use that stacked bar, because that will really help them understand where those new infections coming from. How do we address our PMTCT programs to make sure that we can address prevention among women who are of reproductive age or pregnant or breastfeeding, as well as retaining women on treatment. The second thing is to really think about, okay, how can we figure out how to identify those children who are not on treatment, and looking at the age groups, and then what are our modalities of testing and getting the regimens correct for those children who are on treatment so that they're retained on care. Third point is just to say, so yes, we know we've got lower ART coverage in children, but what's really a shame and kind of the double whammy or the double challenge is that not only are they not on ART, but even when they are on ART, they're not virally suppressed. So how do we improve that situation for them? As you notice, I didn't present data on ART coverage among adolescents. We had submissions of data from 55 countries this year. Again, a lot of those countries, I say again because I've said this before, a lot of those countries are the very small countries in the Pacific Islands or the Caribbean, but they're usually zeros or ones or twos. So of the big countries where we really want to look at that ART coverage among adolescents, there's not much data available. And so we need to continue to support countries to have the systems in place to report those data. Finally, just to say the monitoring of the outcomes of HIV exposed and uninfected children over time is an important thing to start looking at. I understand there's a Sunday workshop on this, so I encourage you all to attend, not on the monitoring piece, but on the HIV exposed uninfected children. Just some acknowledgements there to all the partners. And further information, all of these data are available on AIDSinfo.unaids.org by country, by age group. And also a plug for Monday morning, we'll have the launch of the Start Free, Stay Free, AIDS Free progress report, which will summarize a lot of these same data, but for the 23 focus countries. Thank you.